All right. I'm not very technically proficient, everyone, obviously. Anyway, this is Becky Mantle, and welcome to our Becoming Baby Friendly in Oklahoma webinar for June. We are very excited to have Trish McEnroe, who's the Executive Director of Baby Friendly, who's presenting today. I have Trish to record, so we will be, as usual, recording this presentation and sending that the link out to the recording afterwards. So if you have others that weren't able to attend, or you've had other staff you'd like to watch this, that will be readily available to you. So just a few reminders. Mute yourself to eliminate any background noises. Please do not put us on hold, because then music or whatever may be playing on your facilities recording there. So, and we have no way to turn that off. Anyway, I know people are still logging in, so just a few quick announcements. I want to say a huge congratulations to Hillcrest Medical Center in Tulsa, who is officially baby friendly designated, and they are now our 8th hospital, and that means Oklahoma now has about 20% of our babies that are born in baby friendly designated hospitals. So we're very excited about that. We also had our very first baby-friendly hospital, Claremore Indian Hospital, just went through their redesignation visit last week. So, we now have, as we start moving into hospitals that have been designated 5 years and going through, redesignation. So we'll certainly have some good information and feedback from them, and stay tuned as they await their hopefully positive results. A couple of other just quick announcements. We will not be doing a webinar in July due to a number of conflicts, local conference and grandbaby on the way for myself. So, but we will resume in August, and that first webinar for the new fiscal year for us is August 8th. And we're going to actually do a series on the evidence behind the 10 steps and behind baby friendly, and utilize some of the new information that WHO has been putting out, but also what other research is out there to support the steps. The final announcement here is as we make plans for our 7th annual summit next year, which is on February 22nd. We have just hot off the press, we've just gotten our 2 keynote speakers confirmed. One will be Dr. Lee, and there will be Kathy Carruthers, patient consultant, and both are excellent speakers and have held national leadership roles in various organizations. So we will be excited to share more information as we flesh out the plans for that. So anyway, having said all of that, and we still have people I know that are joining in, I'm going to turn it over to Trish McEnroe, and any other introductions or announcements that you may have, Trish, feel free to share, and let you take it from here.
Terrific. Thanks so much, Becky. And good afternoon, everyone. It is such a pleasure to be with you this afternoon, even if it's only virtually. I've only been to Oklahoma once, and it feels like it was only virtually as well. I was at your summit 3 years ago, and I flew in at midnight and spoke at 8 in the morning and left at 11 in the morning. So it was just a really quick drive-by to your state, and would love to come back and visit you some other time when I can stay a little longer. But I joined Becky in congratulating Hillcrest. It was a remarkable achievement, and I wish Claremore every success on the redesignation visit. I don't know what the results are. I don't look at those results. They go to an external review board, and I hear about that just before you all hear about it. So I don't know the results. Can't spill the beans, but congratulations. And,
we wouldn't want you to, Trish.
I'm sure you would want me to, but I just can't. So I wish I could. But anyway, I'm just thrilled to be here, and thank you for having me. So let's move on and talk. Whoops. Let's see. It's meant to hit. Okay. Let's move on. And talk. Becky just mentioned that in the next couple of months, you're also going to be taking a look at the evidence behind the 10 steps to successful breastfeeding. And I'm really excited to hear that, because that's exactly what has just been undertaken by the World Health Organization. So the picture of the document on my screen right now is a document that contains WHO's review of the evidence for each of the 10 steps of successful breastfeeding. And they released this document in, I believe it was November 3rd, 2017. WHO ordered a review of the evidence and undertook a very thorough process from 2015 to 17 because the evidence for the 10 steps of successful breastfeeding had not been looked at since 1998. Lots of amazing studies came out between the last time WHO did the update of the evidence. They felt it was time to pull it all together and take a look at it and see if there was an opportunity to refresh the recommendations that they are making as it relates to the Baby-Friendly Hospital Initiative. One of the things, I'm just back from a meeting in the Netherlands where we did meet with WHO and UNICEF, and the woman, Dr. Rijko Salon, who headed up the evidence review, presented to our group. And she made a point that I thought was really important to make as WHO looked at the evidence. They knew from all sorts of other reviews that have been conducted that there was solid evidence that the 10 steps of successful breastfeeding worked very effectively in conjunction with one another. And so when they undertook this particular evidence review, they did not look at the interconnectedness of the 10 steps. They felt it was really important that they take a look at each of the 10 steps independently and see what the evidence was for each individual step. And so interestingly, they struggled to find studies for each individual step that met their criteria for inclusion. WHO has a very strict criteria that has to be adhered to as they evaluate evidence and make recommendations to nations. And they predominantly are restricted to using randomized controlled trials, which there's some ethical issues as it relates to looking at breastfeeding. So they didn't have a large body of evidence to look at, but they did find some good evidence, and they did look at each of the 10 steps individually, but know that the 10 steps work best interconnectedly, and some of our best studies really relate to the interconnectedness of the 10 steps. So that was just an important point for you to. So there are many of us that have looked at this document and would like to make recommendations to them that additional studies be looked at and included in the recommendations in the future, because we think that it does a good job of getting some basic review in there, but we feel that there's more to be looked at and that the recommendations could be a little bit stronger. So you may want to consider this document as you undergo your evidence review. You may want to take into consideration some additional evidence as you're looking at how you move forward. And that's probably what we'll be doing here in the United States as we consider how to implement the updated guidance. So moving along, this document, which looks very similar to the other document, and let me just go back, you'll notice on the upper left-hand corner of the document that is labeled guidelines. The evidence review is called the guideline. And then this other document, which looks very similar in appearance, is the implementation guidance. This is the guidance that WHO has issued to BFHI national authorities to guide them in the implementation of the guideline that they released in 2017. So one of the things that I will share with you all as one of the roles that I play in the Baby Friendly Hospital Initiative, in addition to overseeing Baby Friendly USA, I chair the International BFHI Network for Industrialized Nations. And so our organization, when WHO released the draft operational guidance for public feedback, my organization got very involved in taking a look at the guidance document and offering very robust feedback back to the WHO and UNICEF. They released this document on October 11th. They gave the public a 2-week comment period, and that was to read, digest, and formulate articulate comments back. And then they had planned to release the final document on November 17th. And so many of us felt that they weren't really indicating a real interest in hearing feedback from the public, but we felt that the document required an extensive review and required significant feedback, and we're able to delay its production until April 11th and take a fair amount of time to really go through it and offer feedback, for which they accepted many of our comments. There's still, I would have liked to have worked with it a little bit more to make it even a little more robust. But I think the final product turned out to be fairly good. So one might ask, like, what triggered the WHO to undertake this review of the evidence, as well as roll out new guidance for the BFHI? They took a look at some data from around the world, and they saw that between 10 and 12% of hospitals globally have a current baby-friendly designation. And they were quite concerned with that statistic. You know, it still represents a fairly large number of hospitals globally, but it's still a very low percentage. We here in the United States very much, thanks to you all for your amazing efforts in Oklahoma and other kinds of activities that are going around the United States that are similar to what you're doing in Oklahoma. We here are now have about a 25% penetration of BFHI. We've just passed a very important milestone this month. We now have more than 1 million babies born in U.S. baby-friendly designated hospitals every year, thanks to all your amazing work. So thank you from the bottom of my heart for all you've done. And so WHO has, they saw what is possible, and they felt that it was important that they reinvigorate the baby-friendly hospital initiative. They feel that every mother deserves the 10-step practices, so they wanted to encourage wider spread adoption of those practices to support breastfeeding. They also were listening not just to, you know, when WHO and UNICEF prepare guidelines, they're not just worried about what's going on in nations like the United States. In fact, many times they're less concerned about our countries, because our countries have the resources and the wherewithal and the motivation to make many of the changes ourselves. They often are very concerned about the non-industrialized nations, or those nations that are still developing their healthcare systems and developing their economies to match a little bit more what ours is. And so they were really concerned that many of the countries around the world, particularly some of our poorest countries, had very low adoption of the 10 steps, and they felt that they really wanted to set attainable goals for those countries to help them move forward. But one of the things that I like about the new implementation guidance is it does call for a scaling up of the Baby-Friendly Hospital Initiative to 100% coverage of all hospitals in all nations around the world. So it's a pretty lofty goal for us to be working to achieve, but I think it's the right goal. And I think we're the right folks to roll up our sleeves and at least do our part here in our country. So let me just move on to the next slide. So there are a lot of messages in this document that I think are really very important. And so I've pulled a couple of them out just to share with you. This is my all-time favorite message. I wish this was one of the comments that I personally had submitted to WHO. It is not, but whoever wrote it really captured the essence of everything that is BFHI. And that is, breastfeeding is a vital component of realizing every child's right to the highest attainable standard of health, while respecting every mother's right to make an informed decision about how to feed her baby based on complete evidence-based information, free from commercial interests, and the necessary support to enable her to carry out her decision. I mean, that is just such a power-packed sentence that really says it all, and I think that's what we're all striving to achieve. And I think that's a really challenging balance for us to achieve, particularly as we balance points 1 and 2. We very strongly believe that every child has the right to the highest attainable standard of health, which means we believe every child has the right to be breastfed. But there's another side of the equation, and that is the mother, that we need to bear in mind what she's capable of doing, what's all that's going on in her plate, her well-being and her health. And so we do need to respect mothers' rights to make that informed decision, and striking the balance of how hard to push a mom, how hard to support her, and knowing when to back off is a bit of an art form that I think we still all kind of wrestle with. But anyway, we'll keep working towards that. Another really important message in the implementation guidance is they very clearly state in one of their call-outs, the first few hours and days of a newborn's life are a critical window for establishing lactation and providing mothers with the support they need to breastfeed successfully. So I know that this audience knows that information very well. I don't need to elaborate on that. And that the core purpose of the Baby-Friendly Hospital Initiative is to ensure that all mothers and newborns receive timely and appropriate care before and during their stay in a facility providing maternity and newborn services, to enable them to establish the optimal feeding of newborn, which promotes their health and development. And that by reinvigorating the BFHI and ensuring that all facilities adhere to evidence-based recommendations on maternity and newborn care, breastfeeding rates can be substantially increased and the health of mothers and children dramatically improved. And that the implementation guidance, as I've already said, calls for nations to plan for a universal coverage of the BFHI and to ensure sustainability over time. One of the challenges, I'm sure, our designated hospitals that are on the call know that, we always say success is a journey, not a destination. Achieving baby-friendly designation is one of the key milestones in your journey, but retaining the practices is also a challenging component of the journey, and it's equally as important as attaining the designation. So it's a balanced approach to moving forward and to making sure that we not only achieve, but we sustain. So here's some of the, here's an overview of what this guidance addresses and really gets into some of the things that I'm sure you have the most questions about. Probably one of the most important successes that I would say the BFHI network had in our commenting process to the World Health Organization and UNICEF is that we did convince them that it was vital that they retain the 10 steps of successful breastfeeding in their original order and in their consisting of their original subject matter. If you did not have an opportunity to review the implementation guidance when it first came out in a draft format, you may not realize, but because WHO and UNICEF were really excited about putting a whole new face on the Baby-Friendly Hospital Initiative, they completely reordered the 10 steps to successful breastfeeding, which had many of us extremely concerned because, as I'm sure you all know, none of us speak the entire step language. When we talk about a step, we talk about step 7 and we know that means rooming in. We talk about step 3 and we know that means prenatal education, or step 10 is postpartum support. And so reordering those steps we thought would create massive amounts of confusion. So I'm really excited to say to you that WHO and UNICEF did listen to our feedback, and as much as they were interested in a new face, they did agree that it was a nice idea, but probably not worth the confusion that it might include. They did change the language of some of the steps, and some of that wording changes made the steps a little bit more generalized, and the purpose of that was to allow for the incorporation of new and updated evidence in the future. So you'll see some language changes in the steps. We will probably adopt the language changes when we adopt updated guidelines, and I'll get to that in a little bit. So just know that that's there. We're staying with our current 10 steps for now, and the current guidelines and evaluation criteria. But one of the things that this guidance document does that I think would make it worth your while to take a look at it is that in each of the 10 steps, when you look at the global materials, they do they explain what their intent is for each of the steps, and they offer clear guidance for their implementation. And it's formatted a little bit more like the Baby Friendly USA guidelines and evaluation criteria, where we have the step and we have a guideline and then we have the criteria for evaluation. The global criteria used to just have the step and the criteria for evaluation and no general explanation for how they envisioned a step being implemented. And the inclusion of that in this global guidance, in my mind, is just a really helpful thing. It broadens some of the interpretations beyond what we had previously been seeing. And so I find that very instructive. They've also provided a set of infographics for each step, and the infographics are really nice. And so we'll be rolling those out when we adopt the new steps. So you'll see the infographics as I go through each of the 10 steps. And what the implementation guidance does for each of the 10 steps. So this is the first step. Hospital policies is the broad subject matter. Step one, they made a significant number of revisions to, and this very much aligns their thinking that policy drives practice. The code is really important, and monitoring systems are essential. So they made step one a 3-part step. So it's almost as though they've created 12 steps to successful breastfeeding, but they didn't want to do that, so they made one a 3-parter. So step 1A is comply fully with the International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly resolutions. So that's always been a separate, the code has always been an important component of the Baby Friendly Hospital Initiative, but it's never actually been a part of the 10 steps to successful breastfeeding. Step 1B is to have a written infant feeding policy that is routinely communicated to staff and parents. So that's something that's already in place. And then step 3 is establish ongoing monitoring and data management systems. So in the United States, I would say that we're very lucky that we are pretty well established in 1C through our monitoring tools that are available through the D3 of the 4D pathway, the audit tools. And those are the same tools, as you know, that we use during the annual QI and redesignation process. So we have some good monitoring systems in place. So I'm excited that that doesn't require a lot of changes for us here. But one of the reasons WHO and UNICEF decided to put the code prominently in step 1 is they felt that the code has previously been sort of a PS to the implementation of the Baby Friendly Hospital Initiative. It's one of the things we often leave to the end. And really, if you think about it from the standpoint of policy drives practice, and that what you put in your policy sort of sets the big stage for what ought to be embodied in all aspects of patient care, the code is really important that it be considered up front as you're developing your infant feeding policies. You want to make sure you consider the code when you think about the purchasing of infant feeding products, when you think about the utilization of various patient education materials, when you think about the staff training needs of your organization. Oftentimes, code violators try to offer various things to facilities that may put you in jeopardy. And so I think that the WHO and UNICEF's idea was that we want the code to be out there front and center as a really important piece, and we want information to staff and patients not to be impacted by commercial interests. So I think that's their rationale for why that got put in step 1. As you look at step 1B and read their implementation guidance, they clearly state policy drives practice, and that the facilities, they have an expectation that facilities have a comprehensive infant feeding policy that effectively guides staff to deliver evidence-based care. And I think we here in the United States are really well on the road for that one. We've got a very comprehensive a comprehensive policy checkoff tool that you all utilize, and so I don't anticipate a huge number of changes there. When you look at step 1C, they stress the importance of and propose systems for monitoring and sustaining practices. So again, I think we in the United States are in very good shape for step 1. So moving on to step 2, here WHO and UNICEF really wrestled with the whole idea of staff training and how we want to tackle the issue of staff training for the future. We live now in a world where there's a lot of evidence and a lot of training programs out there pertaining to breastfeeding. And is it just pushing a 20-hour course the right way to go? Or should we be looking a little bit more at competencies as well as pre-service education? So step 2 has been reworded to say that we should ensure that staff have sufficient knowledge, competence, and skills to support breastfeeding. When you read the first version of the implementation guidance, WHO and UNICEF had initially eliminated the training need and called for all training to happen pre-service. It would mean breastfeeding management education would be included in medical curricula as well as nursing curricula, which in theory we all agree with would be a great thing, but that's going to take many, many years before that can be accomplished. And so we did work with them to reinstate in-service training as a part of the Baby Friendly Hospital Initiative until pre-service can be solidly incorporated in pre-service education, and several classes of students have graduated and entered into practice. So we'll be thinking through what step 2 will look like in the future. For now, we're keeping our current 20-hour course in place, but we'd like to think about ways that we can transition to maybe a shorter course and more emphasis on competency verification. So some of the things we'll be thinking about down the road. Step 3 pretty much remains as it has always been. It says discuss the importance and management of breastfeeding with pregnant women and their families. One significant change that WHO has made is that they've removed, in their documentation, they talk about the importance of mother-friendly birth practices and the impact of birth practices on breastfeeding. They do remove the requirement that we talk about mothers about non-pharmacological methods of pain relief as an option as part of prenatal education. What WHO does instead is they say that all healthcare professionals working with pregnant women and new mothers should be knowledgeable about all these practices and their responsibility for comprehensive education to mothers, and they refer them to other WHO guidelines for more details on specific practices, but they don't embed the baby-friendly practices into the baby-friendly or the mother-friendly practices into the Baby-Friendly Hospital Initiative as they had in 2009. Is for step 4, they've changed the language here quite a bit. It says facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible. So here the language change to the step is very significant, but the actual language of the step better reflects what our current practice is. So we don't see much that's going to impact how we practice using step 4. And one of the things I think is really great about the new guidance is that they really put an emphasis as it relates to this step on the safe implementation of practices and making sure that we put in sufficient monitoring systems of patients. We don't expect mothers and babies to be just put skin to skin immediately following birth and then just left on their own, that we do need to monitor, those early hours following birth. And the guidance also does remind all of us of the importance of individualized attention and care. So moving on to step 5, support mothers to initiate and maintain breastfeeding and manage common breastfeeding difficulties. So that's very similar to what we currently have in place for step 5. And they right now have talked about stressing, including breastfeeding support for all infants cared for in a facility, and they have included some guidelines and indicators and standards for providing breastfeeding support for preterm, and a lot of those indicators are woven into step 5. And that's an area where I think we'll have quite a bit of conversation here in the United States. Baby Friendly USA is working on a NICU initiative. It hadn't been our vision to weave that into the regular Baby Friendly Hospital initiative. It would be a separate initiative. So we may part paths with WHO on building those indicators in, but it'll be a part of our discussion when our expert panel meets next month. Step 6 is do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. So here's a step where the language of the actual step has been proven to be a bit controversial for us in popular media these days, but I like the language that they've used on this infographic rather than kind of scaring mothers like we don't provide any food or drink other than breast milk. We support mothers to breastfeed by giving only breast milk unless there's a medical reason, and we'd probably add informed mothers, an educated, informed decision by a mother. But I like the fact that they also prioritized donor human milk when a supplement is needed, and they do point out that we want to, of course, always help mothers who want to formula feed to make sure they do so safely as well. So the guidance does continue to stress the importance of exclusive breastfeeding for 6 months, but it also really talks a little bit about how do we communicate our recommendations for exclusive breastfeeding in a way that we don't make mothers feel guilty or excessively pressured, but that they are well informed of the importance of exclusive breastfeeding, and they have all the information they need to make their decision. Also in this step, the guidance, the clinical guidance does, while they set a clear set of global criteria, they are also giving countries the option to tailor for applicability for our national standards. And so this is one we will probably talk about. How do we best tailor this and get messaging out that is in a constructive, positive way to mothers, continues to provide them all the information they need and helps them support it. We support them in making a good decision. Step 7, enable mothers and their infants to remain together and to practice rooming in 24 hours a day. That remains pretty much unchanged. I don't have any additional comments on that. Step 8 is support mothers to recognize and respond to their infants' cues for feeding, and that too is pretty much unchanged. So I don't have a lot of extra comments on that piece. Probably the single most controversial thing that the new guidance contains is a radical change in the way they're recommending we deal with step 9. And it currently just says counsel mothers on the use and risks of feeding bottles, teats, and pacifiers. It doesn't contain an outright requirement to offer alternative devices. Here in the United States, we are still keeping the current step 9 guidance in place until we've had a chance to hear from our experts how best to go forward with this new recommendation. So I want you to be aware of it because it's out there in WHO materials. We are currently staying the course on this, but that's an area where there's a major change. Another area where the 10 steps offer a major change is as it relates to step 10. It now says coordinate discharge so that parents and their families, their infants have timely access to ongoing support and care. It removes the requirement for the fostering of the development of these groups, but it does reinforce the role of facilities in providing, it does reinforce the role of facilities to help identify appropriate community resources for continued and consistent breastfeeding support, and that the facilities have a responsibility to engage with community resources so that there is good, culturally sensitive and support from others in the community, and that the messages in the community are consistent with the messages that have been provided at the hospital level. So as I've tried to point out as we've gone along, there's some substantial changes in some areas and some no changes at all in other areas. And so just to not stir the pot or get folks anxious about what are we going to be doing and when do we do it here in the United States. What my instructions are to you all right now is continue to follow the current guidelines and evaluation criteria until otherwise notified. We saw all BFHI national authorities around the world saw the new implementation guidance at the exact time the public saw it. And so we didn't know what would be in the final document until it was released on April 11th. And so we have a fair amount of work that we need to do to think about how we go about implementing and what we go about implementing. And so you should stay the course until you receive notification from us to change courses. And the way we will notify you of any changes to the U.S. program is through like the 4 points here on the slide. First, we'll make an announcement on the public portion of our website. We'll post any new guidelines, etc. We will also make an announcement in the secure portion of the website. So those of you who have access to the portal, you'll see it in our notices section. Then we will also announce to all of the Baby Friendly USA contacts via our electronic newsletter. So you all know we've been using that to just monthly send out just updates to you all on various things that are happening around the country. We will also request the key organizations forward announcements to their membership. So we usually, whenever we make a change, we usually reach out to state organizations, statewide coalitions. Becky would certainly be one of the people that we would be reaching out to let know and pass the information on to you all in Oklahoma if you haven't gotten it directly from us. We will reach out to CDC, we'll reach out to the Academy of Breastfeeding Medicine, AAP, ACOG, United States Breastfeeding Committee. So we reach out to our friends to also help disseminate the information. So once we've made changes, you'll be notified through ample means. So what are our next steps? So we've been going through the operational guidance, and we're making some preliminary decisions. And there may be some things that we will implement a little sooner than other things, but we have formed an expert committee. I wrote this slide a couple months ago. We've formed an expert committee that will be guiding the adoption and implementation of the recommendations. So once we receive recommendations from our expert committee, we're going to need to develop a comprehensive implementation and communication plan. We'll need to update our guidelines and evaluation criteria. We'll need to notify training companies of any changes to the training requirements and give them some time to comply with those changes. We'll need to notify patient education materials companies of any new requirements, and then give them a chance to comply and update our 4D pathway, and then give you all some time to comply. So I just want to repeat my initial message. Continue to follow our current guidelines and evaluation criteria until notified otherwise, and we will give you ample time. Once we've made a decision on how we go forward, we'll give you ample time to update your practices and make the changes internally before we start holding folks accountable to that. So that's sort of the end, and I can open it up for some questions.
All right, thank you for that, Trish. I know I can certainly start off with some questions or comments, and just a reminder to those of you, feel free, anyone that has a question, remember to unmute yourself so that you can actually ask the question verbally, or if you prefer to just type something into the chat box. And any questions that we may not get to, or Trish said if she's asked a question that she doesn't know the answer to, we'll certainly circle back around with some responses to that by email as well. So I guess the first question I would ask you, Trish, and knowing what's going on with some of our hospitals here in Oklahoma, we have probably at least 3 that would be up for their official site assessment in the next year, from about this point in time through next summer. So right now, you would say definitely no changes prior to that time.
Absolutely. Absolutely. There will be no changes before next summer.
So everyone that's that's in their designation phase or scheduling their assessment, nothing to change definitely at this point in time. So I'm just going to see if I see anything else. Oh, and then here's a question in the chat box. Once Baby Friendly USA makes decisions, how long do you think it will take to implement those changes? Just in general terms, of course. And thanks for the update. And that's from Gwen. So.
Okay. So, you know, as I've said earlier, I'm very mindful of the impact we can have on all of you and how busy you all are. And so we have, I guess my best way of answering that is to just tell you what we did historically. When we made the shift from the 2010 guidelines and evaluation criteria to the 2016, we gave facilities a year and a half to implement. And there were 2 major changes that we made from one set of guidelines to the other. So clearly it will depend on the magnitude of decisions. If we decide that we can cut back on some of the standards and relieve some of the workload on you all, then certainly we can implement that sooner than if we impose something new. Again, I'm going to try to keep the changes to be the least onerous as possible and the least earth-shattering to you all, but you know, as well, but looking at it from the eye of reducing what we can, any burden we can for you all. So we'll make the appropriate decision, but the last time was about a year and a half that we gave folks for implementation.
And Gwen said, thanks, that's very helpful. So, other questions from listeners today? I know, let's see, somebody else is typing. From Connie, thanks for speaking today. Our facility will be having our survey in September, and we had a question. Our safe sleep information shows a pacifier in the pamphlet. This is from the National Safe Sleep. Will this ding us? Great question, Connie.
It's a really great question. It seems like we collide with almost every issue under the sun. We did issue some statement on our website. If you click on our guidelines and evaluation criteria page, there's some clarification statements off. If there's a menu bar off to the left, and we issued some guidance on how to handle safe sleep and pacifiers. So the recommendation is that if there is that information, that you would make sure that mothers know that the pacifiers should be delayed until breastfeeding is well established.
And I mean, and that's really the current teaching anyway.
Correct.
So it's really just clarifying that this picture on this pamphlet doesn't mean you start the pacifier the day you get home.
That's correct. It's sort of that extra effort. So not knowing, you know, what the picture looks like, I can't say that it won't get discussed, but that's generally how we remedy it. So if that information doesn't appear clear with the assessor, you make it a recommendation to make sure like there's information with that brochure or a sticker on the brochure that says, you know, this information is for after breastfeeding is well established. So just making sure that moms are very clear about what you mean about the use of that pacifier and when.
And
I see the comment. That's the teaching you give the moms. Good job.
Yes, yes. So a question I have actually applies to step 6, the exclusive breastfeeding piece.
Yeah.
That WHO kind of giving countries the ability to tailor to national standards. So can you maybe give an example of that, or what would you consider a national standard in the U.S. that would be tailored to?
Yeah, so and the tailoring to national standards actually applies to them all. So let me just say that. So 2 examples that come to mind. If you look at the WHO materials, they say that the only reason for supplementation of a breastfed infant is medical indication. Our current standards allow for mother's educated choice, and we'll probably retain that. I can't imagine that we'll take that away, but so that would be a tailoring. That would be an example. Another place the United States is historically tailored is as it relates to HIV and breastfeeding. Our recommendations are very specific to our country. There are different recommendations for other countries. So the BFHI National Authority always has that opportunity to tailor standard as would align with their national health recommendations.
Right. HIV is a great example of the difference in recommendation depending on what country and what are the risk and resources.
Correct. Correct.
So that's very helpful. I have a room full here with me, so.
That's okay, and everybody's got, and it's a lot to digest all this information, so I totally understand it. If it needs, if we need to talk about this another time, particularly after we've had more time to digest some of this, you've all had a chance to digest it, and we have too. I'm glad to represent.
Right. I know I will also ask the question on step 2, which is the staff training, of course. And absolutely, we're all sitting here nodding our heads about, yes, we would love to have more education about breastfeeding and pre-service education, so nursing school, medical school, and so forth. And yet that's, is that necessarily going to include, the 10 steps? And then just because somebody had exposure to that in school doesn't mean that, they've got that hardwired when they say go through orientation as a nurse on a mother baby unit. And there's still, I think, quite a bit of. So any other thoughts on that?
So those were exactly the arguments and the feedback that we made to WHO. And I think, they set it as an important goal, and they really felt that it was important that we put it out there and that that be something we strive for. But I think it's many, many years away. So I think in-service education as well as competency verification will be here for a while. And I think, we want to make sure that the greater emphasis is on the competency verification and making sure that, all staff know how to safely implement the practices as well as implement those practices in a way that's culturally appropriate. And let me just say, I keep emphasizing that point. I believe that's what happens across the country in almost every facility. Everybody's mindful of safety and very compassionate in how they deliver their information. It doesn't always get received in the way it's delivered. But, I understand the challenge we have in talking with so many different kinds of people who receive information in many different ways. So, working on, cultural competency will probably be something we try to focus a little bit more on, even though I think people do a great job. It's probably one of those things we can always continue to improve with.
Right. Well, and there's great debate about cultural competency versus cultural humility, I think. And that's the topic of another, for another day, perhaps. I guess I would just maybe elaborate on that question about the step 2 training. Yeah, in the ideal world, and probably not in my lifetime, that we would have all of breastfeeding education in pre-service school and training. But when that ever came to pass, and then if Baby Friendly is going to focus more on a competency verification, and this is quite speculative, and once again way down the road, it would seem like you would actually need to then work on more competencies that you would verify than are currently.
Absolutely.
That's good. Okay.
Yeah, absolutely. And there are a list of 20 competencies in the document. I would probably reframe some of those competencies, and I think that there's some pieces that I would probably tweak a lot. Not just reframe them, but add some different ones and subtract some away. So I think those are things that, as long as we've been given the flexibility to take a look at some of that, and truthfully, we have to look at transition plans. Right.
Oh, right. Yeah, absolutely. I don't envy that task. at all.
Yep. Yeah.
I know, and I have one specific question that's come up recently from just kind of on that whether it's step 5 or step 6, supplementing for medically indicated. Yeah, that's step 6 reasons and use of donor milk. So have you heard from any hospitals that are actually utilizing donor milk on a mother-baby unit, and any problems with that, say with hypoglycemia, or donor milk not being helpful in that regard? Just curious if y'all are getting any kind of feedback.
It has not bubbled up to my attention, Becky, if it's happening. I'm not the one from our team that talks with the hospitals. I have a whole clinical team that talks with hospitals. And usually when there's an issue, it gets bubbled up to me. And it's not coming to my attention. But I suspect donor milk on the mother-baby floors is used on a very limited basis. I think it's more in the NICUs.
Oh, right. So, yeah, as we have more hospitals trying to implement Step 6, and we have a milk bank here in Oklahoma, then there, that's generating interest in its very small volumes, of course. But so would that be Laura that I would maybe reach out to?
Yeah, and Tammy Titus would handle that, and I can email you her address.
Okay, great. Just to see if they're hearing anything on that. So that was our time today. Okay, so we are almost to the hour. Any other questions from anyone else that's in our audience today? Or then give everybody a second there. Otherwise, I think that we will, probably wrap this up and let Trish get about, and everyone else get about their day. And we have 4th of July coming up, so happy 4th of July to everyone. And thanks for joining us today.
Thanks for having me, and good luck to everyone who's has an upcoming assessment. I hope it goes well.
Yeah.
Great.
Thanks for your time.
Thanks so much.
Bye-bye.
All right. Bye-bye.